Good afternoon, everyone. On behalf of the Education and Professional Development Committee, I would like to welcome you all to today's PAI-focused webinar. We are thrilled to have Dr. Siobhan de Urioste as one of our guests, who will present Medication History Program at URMC Empowering Technicians. Our second speaker, Dr. Hinnah Farooqi, will present Developing a Hospital-Based Pharmacy Technician Training Program Recruitment Strategy. Since 2020, Siobhan has served as a leader for the Practice Advancement Team, which blends conventional medication therapy review with an analysis of medication use and medication access to ensure clinical recommendations are aligned with each patient's needs. She was key in expanding cardiology pharmacy services, which will incorporate practice advancement modeling into their practice, and oversees an outstanding team of medication history technicians. Additionally, she serves as mentor to technicians participating in the PTCB certification program at URMC, as well as providing shadow opportunities for high school and undergraduate students interested in the profession. Dr. Hinnah Farooqi is a pharmacy professional with over 14 years of pharmacy management and administrative experience. She has served in both the Director of Pharmacy and Operation Manager roles at large institutions in the New York area. She is accustomed to managing large, diverse teams. Hinnah is committed to staff development, patient care, and process improvement. She also serves as the program director for the New York Presbyterian Pharmacy Technician Training Program. Before we get started, I'd like to share a few quick points. For those who have technological issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist in resolution. For those who have questions that they would like to direct to the speaker, please use the question box or chat option. The CE code for this program will be provided at the end of the program. Thank you.
Thank you so much, Nicole. I appreciate that wonderful introduction. So today I'm going to review the medication history program at the University of Rochester Medical Center. There are no financial disclosures or conflicts of interest regarding the content of this presentation. And to quickly review our learning objectives, I will describe an overall structure of the medication history program, summarize a recruiting and training process, list methods used to measure medication history technicians' impact on patient care, and describe goals for expanding technician-led initiatives. Our medication history technician specialists are a key component of the practice advancement model. The main goal of the practice advancement team is to assess how patients are managing their current medication therapy. If they're experiencing barriers to accessing their medications, if they have difficulty with adherence due to pill burden, or if they're experiencing adverse effects, the pharmacists need to be aware so that their clinical recommendations can align with each patient's specific need. The critical first step to this process is a thorough medication history, because the information the patient provides to the technicians, typically during their face-to-face interview, offers insight into patient needs, and it provides a solid foundation for the pharmacist to then work from. I'll provide some examples later on in the presentation of what this looks like. The practice advancement team here at U of R includes 6 internal medicine pharmacists who are each assigned to a single medicine unit, which has approximately 25 patients. We have our 3 medication history technician specialists, so they cover 2 units each, which is about 50 patients. The patients fall under the MedSurg patient care service and have either been admitted directly from the emergency department or transferred from a higher level of care, such as an ICU. Service coverage is currently Monday to Friday during the day from 7 a.m. to 3:30 p.m. with the hope of expanding coverage to evenings and weekends in the future. If pharmacists have scheduled days off, their patient medication histories are reviewed by the clinical coordinator or a cross-covering pharmacist. When our med history technicians have scheduled time off, The remaining technicians evenly divide the units. Limitations of our current program include limited days and hours of coverage and the inability to cover patients in the emergency department, which results in some patients having been admitted for days to even weeks at a time before transferring to our practice advancement unit for a thorough med history technician review. Medication review and reconciliation remains the provider's responsibility, so the service that we have enhances it for patients admitted or transferred to units with this coverage. So recruitment has been a bit of a challenge, I think, overall for most healthcare institutions. But when it comes to recruiting medication history technicians, you really need to look no further than the talent that you have right in your organization. The medication history technician position here at the U of R is assigned as a specialist designation, which is one of the top levels of achievement for technicians in their career ladder. It offers an increase in salary as well as a desirable schedule with no evenings, weekends, or holidays. Whether the candidate is internal or external, though, there are key traits and work experiences which can improve their chance for success. So acute care and ambulatory care experience is ideal. Inpatient experience is useful as it will help reduce extensive onboarding time, as the candidate will likely already be familiar with the computer system and the units and the hospital process overall. And that allows for a quicker integration into the care team on the patient units. Ambulatory care is helpful as it allows for expanded knowledge of a variety of medications. Given that the hospital has a limited formulary, it may limit exposure to different kinds of medications that patients may come in on. And having that ambulatory care experience also typically helps improve an understanding of the barriers patients may face when picking up their medications at their home pharmacy. Additional traits which are key to success include being compassionate and friendly, having a high attention to detail, being able to work independently, and not being afraid to seek assistance from the pharmacist rather than admitting a knowledge gap and guessing at the information. Not only does this expand their knowledge, but it creates a trusting and safe environment for the team to work in. So one of the biggest challenges surrounding recruitment outside of the diminished workforce is increasing the awareness for the medication history position, since it isn't as ubiquitous a role as the typical dispensing and compounding roles. Utilizing existing resources and frameworks is the easiest place to start. The University of Rochester Medical Center offers an accredited pharmacy technician university, or PTU program, for new hires, and this supports their learning and improves pass rates for the certification exam. The medication history technician program was added to the PTU rotations in 2021. And so the PTU technicians will rotate throughout different areas in the hospital. And traditionally it was compounding and inpatient and outpatient. But the med history program was added. And essentially what the students do is they spend half the day with the med history technicians and the pharmacists to showcase the unique opportunity to interact with patients and to be able to see firsthand the positive impact of their work. This has quickly become the top-rated experience reported by technicians in the program. We have about 36 students per year, and before they leave us for the day, they're provided contact information so that they can keep in touch if they're interested in fulfilling this position in the future. Once the medication historian is hired or promoted from within, training is the next essential step. Training lays the groundwork for expectations as well as core values and culture of the team. Our core requirements is designation as a certified pharmacy technician, And then institution-specific training includes competency in navigating the electronic health record, HIPAA compliance, passing infection prevention precaution training as they will be entering patient rooms, and medication safety policies such as look-alike, sound-alike, and high-risk medication lists. Training specific to the position covers the standard operating procedures for obtaining what we call the best possible medication list. To assist our new hires with a comprehensive understanding of the goal of their position on the healthcare team, they are tasked with reviewing a couple of references that I've included here. And these are just examples. So we've really liked the marquee training video on taking a good medication history. And there's a pocket guide as well, so that they could use that as a reference. And then there's Dr. Jeffrey Schnipper's presentation on the importance of the medication history. And recently added was a document called Access to Care, Development of a Medication Access Framework for Quality Measurement. This is through the Pharmacy Quality Alliance, or PQA, and it emphasizes the importance of communicating patient-reported barriers to obtaining or using medications. And what we really liked about this is it helps set the tone early in training to focus on key information regarding a patient's ability to maybe afford their medications or remember to take their medications or any other barrier to care, in addition to just providing an accurate medication list. The med historians, the current med historians share responsibility of the onboarding process for new hires. They explain the steps in the standard operating procedure, or SOP, and support the new technician throughout the entire process. So what does this look like? A minimum of 5 patient interviews are conducted by a seasoned med historian and must be observed by the new hire before the new hire can attempt one on their own. And that's just so they get a pretty good understanding of the process. And because this position is patient-facing and interacting, we want to make sure that we're setting the new hire up for success. Because the process differs based on where the patient is presenting from and their own specific needs, the newly hired technician must be familiar with working up patients from a skilled nursing facility, as well as those who may need interpreter services. We have American Sign Language and Spanish interpreters on site. And then we also have a virtual program, which is available on tablets on the units, which covers all other languages. And it's crucial for the trainee to be familiar with key processes for as many different patient scenarios as possible to build their confidence. Following the shadowing period with their trainer, the new hires then move into doing the process themselves, which is probably the more exciting part of their training. So a minimum of 10 patients must be worked up and submitted, and these submissions are reviewed by their trainer before they're sent to the pharmacist, just to help provide in-the-moment feedback and any edits that might be required, so they get a good feel for the expectations for accuracy. The duration of training depends on the experience the technician had prior to transitioning into the role, but is anywhere from a month to 3 months or more. And so before they pass training, they also have to complete a written competency with a minimum of 80% on that written competency. And they also must independently and accurately work up 5 patients on their own. And that includes performing the interviews, documenting their findings, and submitting it to a pharmacist with complete accuracy. Following the initial passing of their training, the medication history technicians have biannual assessments with a pharmacist supervising their interview techniques and adherence to the standard operating procedure to maintain consistency and standards of care. So here I'm just going to show you an example of the written competency exam. So a lot of the questions we have are related to an understanding of medications. And then as you can see, question 4 is understanding how to proceed if the patient is confused and they don't know any of their medications. And it kind of highlights all the key aspects, whether it's medication information or being able to confidently and competently address a patient. Here's an example of our standard operating procedure as far as the biannual assessment, and this is also used for end of training assessment. Adherence to the SOP is crucial because there should be consistency in approach to patient review. The other nice thing is it offers an objective measure of competency in the event that there are performance concerns. And I'll also add that it is also helpful in the event where, for example, we had some instances of pharmacists requesting technicians to select or document on patients in particular ways. And because our technicians are kind people, they would do it. And also to avoid conflict with the pharmacist. But it got to the point where they were trying to track how each pharmacist wanted them to perform certain steps, and that resulted in stress on our technician team. So the SOP was used to reinforce that the technicians need only follow the steps outlined in the protocol, and it therefore protected them from these extra requests. So I'm moving on to one of the most important aspects of the entire medication history process. And if you happen to have a medication history program in place at your institution, you already know how incredibly valuable this service can be. However, capturing the impact is one of the biggest challenges. But that impact is vital to support the program and drive expansion of services. One method for success is to tie outcomes of the program into healthcare aligned goals. So 2, which can be converted directly to cost savings, is a reduction in medication errors, which can lead to shorter lengths of stay, and lowering rates of 30-day readmissions. Both of them are monitored by the Centers for Medicare and Medicaid, or CMS, and impacting these 2 variables can decrease monetary penalties to your institution. Patient satisfaction is also a metric captured by CMS, but more importantly, it's a vital contributor to the community's view of your healthcare system, and it can drive greater utilization of the healthcare services both in and out of the hospital. So here's an example of how we capture some of our metrics in our electronic health record, which we happen to have Epic. And the technicians, as they fill out the information for their medication history, it requires all of this extra documentation. However, this extra documentation on the front end of the process can significantly and does significantly reduce the amount of work in quantifying the impact and reporting it on the back end. So this is an example of the Epic Smart Form captured for medication history technician data and interventions. Not only does the information cross over into a formatted progress note for the pharmacist to place in the chart, but they also it also gets reported into a Power BI program where we can review it. And I'll show that to you right here. So here's a snapshot of the information that's captured in that smart form. And this is from January to November of last year. I can easily assess the number of individual patients reviewed, which is 2,190. And as you can see, some of those patients were readmitted within this time frame because there's 2,409 encounters. The different types of interventions are visible on the left and represent the impact the technicians had. And on the right, I can see that 93.5% of our patients required an intervention, which was which was captured by our technicians' great work. And stated another way, you could say that only 6.5% of patients had an accurate medication list, which required no modifications when reviewed by our technicians. This data looks fantastic, but one could argue that the interventions made may not be considered clinically significant. For example, the technician may have found that a patient was taking a laxative, which needed to be added to their list, or perhaps they were on a multivitamin, or a multivitamin was listed on their home med list, but the patient doesn't take it anymore. We could argue that in some circumstances, those interventions are clinically significant, but to further drive the case for med histories, we look at the data a little bit further. And here we could see there's a calculation of the average number of changes per encounter. And on average, per patient encounter, our technicians are finding about 6.7 interventions. And it's a pretty difficult argument to say that all 6.7 changes to the med list are likely not clinically significant. But the med historian's impact goes much further than just updates to the medication list. And here's where I like to talk about how our team is so empowered to help our patients. The pharmacists use the information that our technicians share with us to drive high quality patient care. Our technicians identify patients who perhaps don't understand why they need to take their medications, or they don't know if they're using it correctly. When a patient takes their twice daily medication at the same time once a day, it provides the pharmacist an opportunity to discuss their medication regimen in greater detail and assess the patient's health literacy. When the technician reports to us that a patient lacks transportation to the pharmacy to even pick up their meds, it offers us a chance to talk with the patient and provide them with a list of pharmacies that offer free delivery. When a patient hasn't been taking their medications due to cost or prior authorization, the pharmacist can get involved and assist in identifying lower cost alternatives. And overall, honestly, the technicians improve the pharmacist's ability to recommend medications that meet patient needs, and it improves their ability to be successful with their therapy. And that is what is considered value-added care. Similar to our med history interventions, these barriers to patient access or use of their therapy is also documented in an Epic Smart form, and then it's reported out here for us to see. So our med historians help us identify patients who perhaps need refills on their home medications, or we need to check the cost of their medication before they're discharged, because the last thing we want is for the patient to go home and get to their pharmacy and realize they can't afford that medication that we recommended for them. It helps us optimize adherence by cleaning up complicated regimens. And we'll get into a couple of the others in just a moment, but these are just a few of the many examples in which our med historians help us. From a CMS 30-day readmission reduction standpoint, Epic is also utilized to capture discharge rates. We're able to capture discharge rates with medication history technician and pharmacist involvement, which you can see here on the left is a 12.88% for January to November of last year. And when a pharmacy technician and a pharmacist are involved in patient care, our readmission rates are 11.4%. And again, our work within documenting that we did the med history and we reduced barriers to use of medications, it all gets captured in Epic and reported out. So I hope I was able to convey the incredible resource medication history technicians are to the healthcare team. They are encouraged to create their own goals, and over the past few years have expanded our services by identifying patients in need of med packing services, assessing whether a patient has their diabetes testing supplies and pen needles at home to allow a safe discharge for patients on insulin, and documented patients in need of education. Our med history technicians have also been encouraged to get involved in team activities, including Pharmacy Wellbeing and Resilience Committee. And they also get to know the nurses and providers on the units, which allows them to feel comfortable approaching them in the event a patient requests assistance during their interview. The med historians are also empowered to mentor pharmacy technician university students or PTU students, and they're responsible for training our pharmacy interns as well as our residents in the medication history process. This has allowed them to become a well-respected and integrated part of the healthcare team. I hope this presentation has provided ideas on how to start or expand a medication history technician program. I have Bevan, our certified pharmacy technician and med historian, here to help facilitate any questions you may have. I see we have some questions in the chat. So I'm going to start at the top. Let's see. All right. Can you speak to how the handoff from the medication history tech to the pharmacist occurs? Is it manual from person to person or built into the EMR to notify the pharmacist to review their work? I can answer that first. In our electronic health record, there is a status which the providers can, well, there's a status on their prior to admission medication history. And when that status is switched by our med historians to pending pharmacist review, the pharmacists get an in-basket notification that we have a med history ready for us to document on. And then how do we communicate with the tech if additional details need to be confirmed or updated? I'll have Dawn answer that one.
So they communicate with us in a couple of different ways. First of all, though, if I feel that there are additional things that the pharmacist needs to know or that perhaps might be not as clear to them when they go to do the med history for the patient, I will just take it upon myself to seek out the pharmacist who is already on the unit and try to explain to them in more detail that this is what the patient is looking for. So that's one way that we'll do it in person. And the other way is that we have the Teams or secure chat on our system, and they will reach out to us and let us know, or definitely give us a call on the phone that, you know, I'm just a little more wondering about some of these things. Can you just touch base with me real quick and clear it all up?
Yeah, hopefully that answered your question. There's so many ways that we can get in touch with each other nowadays. It's almost too many ways. How did you determine to place the med historians on these units after admission versus in the ED prior to admission? I can help answer that question. Dawn was actually here when we first started this program. I was not, but having only 3 med historians in an ED full of hundreds of thousands of patients coming through, because we are a large healthcare system, we wanted to measure impact on a smaller scale. So that's why we were able to obtain 6 internal medicine pharmacists, and it made sense to tie the med historians to those pharmacists to have a more focused coverage. Our technicians do prioritize patients. They have an acuity scoring tool that they use. All right. Do the med historians complete this form in place of entering an IVent, or do they do both? And I believe they're talking about the SMART form.
Okay. So we don't do the SMART form.
We do use the SMART. So they do use the SMART form to document their interventions, and we do not use IVents.
Okay. That's, yeah.
Yeah. And
have the information, but it's on a different form rather than a specific IVent.
Correct. And the rationale behind that is because the IVENTs, it's very difficult to pull data out of IVENTs. I'm just gonna answer the next one and the providers do not see the information in the smart form. And is everything completed in Epic, or do technicians use paper to write and or track changes when speaking to patients? Our technicians and pharmacists like paper, but we would like to move away from that. I'll have Don answer that one.
So we do use paper. It just seems to be an easier way for us to keep track of what the answers are from the patients at that time, and especially if the pharmacists have us come back and review what the answers have been. We can definitely see that this is what the patient has said, and we have some documentation on it.
Yeah, well, thank you. I can help answer, we're happy to help answer any questions at the end. I'm gonna go ahead and turn it over to Nicole.
Okay, we're gonna switch speakers now, and if we have some time at the end, I know there's a couple more questions that weren't answered. If we don't have time for them at the end, we can always email out those, but I will introduce Dr. Farooqi again. Dr. Farooqi, I think you are muted. I'm not sure if you're speaking.
Thanks, Nicole. Thank you for that introduction, Siobhan. That was an excellent presentation. So I will be presenting developing a hospital-based pharmacy technician program, a recruitment strategy. I have no financial disclosures or conflict of interest to report. So today we're going to be learning a few of these objectives. I will explain how a hospital-based pharmacy technician program helps recruitment efforts and mitigate the technician shortages. Secondly, I will describe the primary skills a technician should obtain through the training program. Thirdly, we'll go into a conversation on how to develop a curriculum that meets accreditation standards for pharmacy technician education and training. And lastly, I'll provide a criteria for evaluation of the program. So we know that during the COVID pandemic, this shortage gained visibility. The technician shortage was significant, widespread, and it's been a long-standing problem. The American Society of Health System Pharmacists, in 2021, they conducted two large surveys. They found that hospitals and health systems were experiencing severe shortages. Many of the institutions did report turnover rates of at least 21%, and approximately 1 out of 10 noted they had lost 41% of their technicians. So these shortages, combined with the growth in pharmacy services and a need for specialized training, has created a situation where the demand for technicians outweighs the supply of qualified candidates. If we look at the U.S. Bureau of Labor Statistics, it shows that employment for pharmacy technicians is projected to grow 7% from year 2023 to 2033, and it's faster than all of the other occupations. And we know this is in part due to pharmacists being pulled to perform more patient care activities. So we need a lot of technicians, boots on the ground, running pharmacy operations. So if we look at our traditional recruitment methods, we know that recruitment is challenging, especially for the institutional settings. Traditional methods like job postings are not sufficient to overcome this shortage, and a lot of times it doesn't yield the qualified candidate that we require. Additionally, a lot of these recruitment efforts take months. They increase your overtime, and it also causes for a loss of productivity. So what organizations are starting to do is they're using this new approach to combat shortages. They're trying to institute pharmacy technician training programs, and this can definitely expand the recruitment pool. It's a growing strategy that's being used. It also creates a steady stream of qualified candidates for open positions, and it helps minimize that time to backfill. So during that ASHP technician shortage survey, it revealed that pharmacy administrators reported quite a lot of functions that their technicians were doing. The main functions included sterile compounding, inventory management, purchasing, non-sterile compounding, hazardous drug handling, controlled substance management, medication order distribution, some supervisory responsibilities, billing, reimbursement, and technician education and training. So from this, we can see that there's quite a lot of entry level and advanced roles that technicians play. So we had mentioned quite a few of those entry level, but it does include pharmacology for technicians, pharmacy law and regulations, also includes pharmacy quality assurance. For the more advanced roles, we see that some states allow for tech-to-tech medication programs. And as we heard with Siobhan's presentation, so medication history assistance is something that technicians are playing a greater role with, patient assistant program, prior authorization. So these are quite a lot of the advanced roles that we're seeing. So what are the primary skills a technician should obtain through a training program? The basic skills that we want to focus on, this is for an entry level position, would be personal and interpersonal knowledge and skills. Basically, this includes ethical conduct, time management, how to communicate clearly, teamwork, and conflict resolution. And then it would be foundational knowledge and skills. So this would be your basic pharmacology, understanding the technician role, understanding the medication use process, and other emerging therapies. They would also need to know how to process medication and medication orders. This would be in all settings, including retail and institutional, sterile and non-sterile compounding, procurement, billing, and reimbursement, patient and medication safety, technology and informatics. Advanced technician roles, electives can be added to your program to prepare them. So this is a very loaded, packed slide, but I will simplify it. So for us, if you're initiating a pharmacy technician education and training program, there's 6 large buckets that you should be prepared to tackle. And I would definitely say after running a cohort for over a year, the getting started is probably the only hardest part. Once you establish this program, it does run smoothly. So number 1 would be establish your program. So what is your strategic plan? You know, you have to have a purpose, a mission, measurable goals and objectives. You do need a evaluation process, and you need a way to measure progress and outcomes. Then you need to define who the program director will be and what their responsibilities will be. An advisory committee has to be created, and they have to meet at least twice yearly. You have to ensure that non-discriminatory practices are being used. So if you have students that have any handicap, they are given the equal needs as students without. And then prepare an informational about the program. What is the program going to cost? What is the enrollment mechanism? What are the program requirements? And if there's policies that are needed, such as dismissal policies, they need to be incorporated, and you do need to maintain these records for at least 3 years. The next bucket is the program faculty. So the 3 main program faculty would be the program director, and this person would oversee the entire program. Then it would be the faculty and instructors. They do require a minimum of 3 years of expertise in that area, and same goes with the experiential site coordinators. These might be on-site or off-site for your organizations that want to advance with certain specialties. They can visit other sites. After you've solidified that, then we have to develop the curriculum. So we need to make sure our curriculum is not only preparing students to be either in a retail setting or institutional setting, but it needs to encompass many different settings. The program must be current. Also, we have to define what is the program length and composition, how long will that program run, Are there different sessions, didactic learning, simulation, and experiential? All three will be very important for your program. And at the end, we want to make sure we have education and training goals. And these will be current goals and any future goals that you want to accomplish. So the next would be the students. So you want to make sure that you're discussing the recruitment process, and this basically will involve your coordination with your HR business partner. You will have to decide if there's a basic reading and math proficiency that you will require. And again, background checks, all the processes to onboard staff would be applicable in this situation. For acceptance of your students, you have to come up with a decision if you will require math or reading assessments or some assessment exam, and then again, establish the enrollment program. What's quite important with these programs is the evaluation and assessment process. We want to make sure that this process to review students is systematic, it's standardized, it's ongoing, and we want to make sure that it's moving towards the goal of graduation. A program also needs to prepare students for post-graduation. So if you want to prepare the students for employer accepted or nationally recognized certifications, that has to be some informational or sessions that you need to add to your evaluation process. If you require registration or licensure, that will also be part of this evaluation process. We also want to make sure that we include faculty evaluation and then program assessment, and we'll discuss that later. And at the end, so this is sort of the fun part, is the graduation and certificate. So what are the conditions of graduation? So now I'll talk a little bit about the program at NYP, New York Presbyterian. We host a 16-week program. It's a paid full-time learning opportunity. We prepare our trainees for certification exams, either through the National Healthcare Association or the Pharmacy Technician Certification Board. Our departmental faculty includes 18 full-time staff members, and this includes members from inpatient, retail, specialty, regulatory, patient safety, finance, and procurement. As I had mentioned before, we have two cohorts, one at the Queen site and one at the Weill Cornell site at NYP. We established our processes over a year ago. We've been very lucky to have over 100 individuals at every cohort that applied to this position. We do enroll 2 students at each site, and so far we've had 100% enrollment, that is 12 students, and then 100% a graduation rate. And for certification and license, we've had 7 of our 8 students get licensure. We had 1 student, unfortunately, that moved out of state. And our employment status, we do not guarantee employment status, but as we know, through this technician shortage, we require those skilled technicians. So we've been able to hire 7 of our 8 technicians that have graduated. So this is a little bit of a program overview. As I had mentioned, we have a didactic session. And so what NYP did, we partnered with our external vendor to provide these modules through Pharmacy Technician University. And we have our students do these on site. Through the PTU, we also have 66 robust simulation sessions. And again, I'll speak to this a little later. With that, we have the experiential rotation, and this is the hands-on opportunity where our students get to work with our pharmacists and technicians and other healthcare professionals. So the way we've broken out the hours, for didactic, we have about 137 hours. Simulation is about 79 hours, and the experiential hours are the longest, where our students get that hands-on. So this is a slide that just sort of shows that with our vendor, there's a lot of interactive videos and challenges that the students do, and then they actually go into the environment. We start with simulation, so it will be a simulated environment, and then we will have our students move into the real environments. So if it's IV compounding, they will learn how to don with a preceptor and also make that product. Similarly with anything that's compounded, or they work with our automation, scanning products in and doing inventory. So these are a lot of different buckets we have. So how do we assess our students? So for our program, we do have, with every module that's completed, we have quizzes. There are unit exams, midterms exams, and a final. We do have, with quite a few of them, there's not only one attempt, but our students are very successful, usually passing with the first attempt, and we have a score that we require for them. For the midpoint evaluation, here's the opportunity where our preceptors get to speak to the students, get their feedback, and see where they might be struggling and assist. The simulation component, that is a verbal and written feedback. What we've done here is we've created a standardized, itemized assessment checklist. So that feedback could be shared with all of the preceptors, and we can assess that later on. So it's standardized. Similarly, with the experiential component, it's a itemized, standardized checklist, and students have to be either highly proficient or proficient to pass those. So this is quite important. So that's the program evaluation. So we want to make sure, how do we know our program is working and it's successful and we're achieving our goals? So first we have to establish what are the program goals. So you're going to identify, will it be graduation rates, a national exam passing rate, job placement? Make sure that those are evaluated. You select and then you evaluate. You want to make sure that you have an annual review process. When you do set up your program goals, if you want accreditation, you want to make sure that it's revised every 3 years to be current. You want to also evaluate your goals not only for success, but also for course correction, also to improve the program. We want to regularly also review feedback from the program, and this is not only student feedback, it's faculty feedback and your advisory committee feedback. And we want to make sure that we have a continuous improvement program to incorporate all of the feedback. And for our program at NYP, these were our goals. We wanted to obtain accreditation, and I'll speak to that later, why that's really important. We wanted to expand our experiential experience by rotating through the site. So if one site had expertise on pre-packing medications and they had that technology, our students would go there. And if some other site had robotics, or they had excelled with the IVs or chemo, the students would go to that site. And we also wanted to maintain a 100% enrollment rate, which we've been very successful in doing. We wanted to maintain a 90% graduation and completion rate. We did want to maintain a 100% pass rate on the certification examinations. We had a goal of 50% placement of trainees into our own pharmacies at NYP. And this is one of our future goals. We want to expand this to include community involvement and telepharmacy. As I had mentioned before, student feedback is very important. We did want to maintain an 85% satisfaction on surveys. So how did we do? This is actual feedback from our students. We have a smart sheet that's developed that goes to the students, and they get to rate us on different aspects of the program. So we can see the overall satisfaction with our program. Our students were quite satisfied. We asked them, did this prepare you for your current role? And again, they were quite satisfied with that. We asked the question about the didactic course content, and they were extremely satisfied with that. Our partnership with our vendor was extremely helpful with that. For the simulation portion, equally satisfied. Here's where we ran into a little bit of satisfaction plus dissatisfaction. It was with the experiential content. Then for our satisfaction with the faculties and resource we provided, they were very satisfied. And we asked them, was this training relevant to the skills and knowledge at your current job? They were very satisfied. So we sort of knew what worked and what didn't work. So this is what went well. We know the hands-on, on-site training was a hit with all of our students. If these are actual quotes from the student feedback. One of the students said, I loved every second of it. The length of the program was also good. Another one said, being able to get advice from other pharmacy staff was a main help in knowing what I have to look forward to on my certification exam. So that partnership with the staff on site really helped. What areas where we could improve on? So initially when we had started the experiential process, I believe it was, unfortunately more shadowing where the students felt like they weren't actually doing. And with experiential training, you want to emphasize the doing. So I think that was a common thread. Because this program is quite long, it's either 12 to 16 weeks, I think that need for a clear outline of course content from the beginning was something that they had commented on. And all of this feedback we did incorporate into our process. I know that when our students were doing their didactic training and their simulation, we tried to hold off initially the experiential to the end, but what we learned was we should group all of this together so it is more meaningful for the students. And the last comment I would say, students wanted to make sure if they were trained in IVs, they did their simulation, they wanted that hands-on training. And again, they wanted it with a very knowledgeable preceptor. Sometimes we have our trainees round with regular staff, and that was helpful, but not as helpful as an experienced senior. Not all technicians have the same capability of training we learned. So this was the fun part, right? So it was the graduation and diploma. So we made sure that after our students graduated, we celebrated that event with at both sites. We did have certificates that were produced, so they can use that if they needed to provide it for certification for the NAH or PTCB examination. So here are some of the lessons we learned. So we learned that the program feedback is vital to our evaluation process, and it's needed for continuous improvement. There were a lot of feedback that we incorporated into our sessions. As I had mentioned, we had saved all the experiential component at the end, so it sort of broke the students had all the didactic learning, and it was so far at the end that they felt like they were shadowing more and not doing. So what we broke our weekly training sessions to include didactic, simulation, and the experiential was tied right in. We made sure that a very senior pharmacist or technician that was dedicated to that was included in that experiential process. As I had mentioned before, we had said, why accredit your program? I think accreditation is so important because it allows for that objective review. It helps us align with national standards of quality and excellence, and it enhances our program credibility. We try to hire all our students within NYP, but we know that sometimes we don't have open positions and our students will be going to other institutions. We want to make sure that our program is reputable, so anyone that hires our students know that they're well trained and can cover a large scope of activities starting from entry level to advanced. And I think that's why it's so vital to have the accreditation process. We also learned that collaborating with other sites that had pharmacy technician programs can definitely facilitate the initiation of the program. As I mentioned, after leading 3 cohorts and running this program for over a year now, we definitely valued that input that we had with other sites. We did reach out to NYU that had a technician program going, and I think that was critical to the success of starting our program. And, to sort of summarize, the success, after we instituted this pharmacy technician program, it definitely created a steady recruitment pool for us, and it provided a stream of qualified and skilled technicians. I can say that we have 11 hospitals under NYP. Once our students graduate, even before they graduate, we have so much interest from other pharmacy and pharmacy directors. They want to make sure that once these students graduate, we share their names so they can be hired at those positions, because the students that are currently there, we've had such positive feedback from the sites that the students are really striving at their institutions. That's the last slide that I have, so we can go into questions.
Thank you, Dr. Farooqi. Just a one question that came through, I guess it's two parts. One is, have you thought about tracking successful placement of the students that graduated your program with employment afterwards? And the second part being, what's the next steps for the program? Where do you envision it going from here?
For the first part, we absolutely have instituted a way. We tell our students before they leave, we try to stay in contact with them. If they haven't been hired at NYP, we do ask our students to let us know where they're currently working, and we have an employer feedback form, so we will send it to them just to gauge how the students are doing at other sites. And Nicole, I'm sorry, can you repeat the second part of that question?
Yeah, so the second part was, where do you envision the program going from here? Any changes, expansions, etc.?
Yeah, absolutely. So we, after our initial success, we do want to expand our students. So instead of having 2 students at each site, we definitely want to expand to 3, 4, whatever each of the facility can absorb. We want to make sure that at this point, we're at an entry level. We want to sort of expand that advanced level roles. We do have a lot of coordination with our enterprise team to incorporate students into medication history, also patient safety, procurement. So there's a lot of buckets. As I had mentioned, telepharmacy is something that we're interested in having our students expand to. So that will probably be our next steps.
Wonderful. Another question just came through. Do you have instructors, or is there only a program director?
So we definitely have instructors. As I mentioned before, through both campuses, we have about 18 instructors. Some of them are on site at each of the campuses, and some are located in our enterprise office.
It looks like we have time to answer just the one question that was outstanding from the first presentation. If Dr. Urioste, if you wanted to address that last one that's in there.
Absolutely. The patient assistant programs from pharmacy companies, once a patient's identified as struggling with cost of medication, there's multiple avenues in which the pharmacist will take depending on what the need is. One of them is certainly to look for the assistance programs. I've also helped some of our patients fill out an application for Epic co-insurance. And so a lot of it is working not only with their outpatient pharmacy, but also with our social worker. And so it depends on what the patient's need is. If we are able to find an alternative that is covered by their insurance, that's of course always our first step. But at least knowing it's an issue, if we can't resolve it during their hospital stay, we will submit a note to their primary care provider as a handoff so they're aware.
All right, thank you so much. Now that we're at the 1 o'clock hour, I'd like to thank you very much to Drs. Urioste and Dr. Farooqi for providing today's webinar.